Here's a number that might shock you. More than 20% of Medicaid enrollees lose their coverage every year, not because they're no longer eligible, but because they can't navigate the paperwork. We're talking about almost 80 million Americans who are covered by what looks like one program, but is actually 56 different systems, each with its own rules, forms, and bureaucratic maze. My guest, Nikita Singareddy, became obsessed with this problem and built Fortuna Health to be the TurboTax for Medicaid. And now, with new policy wins on the horizon and an increased and ever expanding policy stack, new federal work requirements and 6-month renewals, this maze is about to get much more complex. This is the Policy Stack. I'm Lisa Berry, and today we're untangling why keeping Medicaid coverage is so much harder than it needs to be. Hi, Nikita.
Hi, Lisa. That was a great
So,
intro.
thank you, thank you. Yeah, it cannot think of a more timely conversation to be having. It is, and I think interestingly for me, it's something you've been working on for quite some time now. And I would love to just get a little sense of your background here for the audience. You've talked about being obsessed with understanding Medicaid policy and implementation, which is my particular passion, the implementation of policy in the real world. I would love to know, what specific experiences caused you to start Fortuna Health and become obsessed with Medicaid policy.
Yeah, absolutely. And I will try to keep it quick so that we can get into the nitty-gritty and some of the details. But I started my career at Oscar, and I think for folks that know anything about Oscar, it is an incredibly entrepreneurial culture where people are really encouraged to look at first principles and understand why are
Mm.
things the way they are. Should they actually be that way? And what if you could imagine something different? And so when you are at least the age I was, 21 years old, learning about risk adjustment and seeing some of the most complex parts of just how health insurance works, that for me was the foray into getting really excited about the some of the strangest corners of healthcare infrastructure and how it underlies a lot of the things downstream on even the care delivery side. So Oscar, the entree for me and many other founders, then was a healthcare investor, then spent time working on 340B and Medicaid on the pharmacy side. So that was my first, I would say, physical foray into what is the actual day to day for community health centers for people who get and receive their care in clinical settings like an FQHC, and recognizing that there really are two healthcare, if I had to put it crudely, two types of healthcare. Two ways of accessing healthcare, particularly for folks that are on government programs like Medicaid. It's almost a night and day difference from commercial insurance. So that was part of just the different things that had happened to me, or the different ways my career had gotten me closer and closer to Medicaid. And then when my co-founders and I got together, one of the, or I'd say two of the things that we were really passionate about. One was, I think if you're going to build a company in healthcare, how do you focus on and find a really hairy and intractable problem? There's a lot of different things you can go after, and they're all important. I don't mean to denigrate, creating different types of companies, but Medicaid had looked, as the more we looked at it, it was replete with different challenges that I think people had been afraid of trying to solve because of the complexities. But I think that's what makes some of these challenges the most exciting to dive into. And then the second thing was we were also looking for what we felt like was a technology problem that had a technology solution associated with it.
Mm.
There's many things that are a labor supply problem, and maybe the best solution is actually more of a policy change versus a technology company or something with a patina of technology on top. And so we felt like solving Medicaid navigation and Medicaid E&E felt like the sweet spot for us.
Yeah, definitely. So, I think when you started to build Fortuna, it was a moment in time, during the COVID pandemic, the height of the COVID pandemic, I should say, where there were all kinds of interesting things happening around redetermination. Speaking of sort of policy wins and the way that actually looks like, one of the things that happens that's really consequential is when someone's particular status, their income levels, or other particular characteristics that would make them eligible for Medicaid are redetermined or reassessed, right? And can you talk a little bit about that moment where there was sort of this COVID-19 redetermination flexibilities and how that affected your founding of Fortuna?
Yes, absolutely. So during COVID and the public health emergency, the federal government at the time under the Biden administration basically told most states to pause redetermining folks for Medicaid and a variety of other government programs. And what that meant was a lot of people stayed on and were not asked to recertify at the typical times that they were asked to recertify. What that ended up happening was that compounded and people who for a year and a half had not been redetermined and asked to recertify whether they qualified or not and provide net new information. So at the end of the unwinding, or sorry, at the end of the PHE, then the federal government and states started instituting different practices around how are we now going to recertify and redetermine whether people do or don't qualify for Medicaid and some of those other government programs. And states took totally different approaches to how they wanted to do that. Some states essentially just restarted if you when you're up for recertification, we're just going to put you back on your general cycle. A number of states started instituting ex parte processes, aka using different data sources to automatically check whether or not you should qualify and recertify. And then if they didn't have that information, asking folks to provide it. Some states even came up with risk algorithms of who do we think is most at risk for falling off? Can we actually, or being unable to recertify on time? Let's move them up first and give them the most amount of time to recertify. So states tried a lot of different things and the federal government gave them a lot of flexibilities, but we still saw that because the process was also new for so many people, it was being done in a very different way. Many folks were not able to recertify correctly or on time, causing almost 10 million people to fall off and no longer qualify or have Medicaid. So for us, seeing the unwinding happen at the time where we were starting a company, I've said this a couple of times, we were too early when we started building the company. The unwinding had already started to happen, but it did allow us to really see in a different way how people were experiencing it. And people also threw the baby in the bathwater at
Mm.
recertification. They tried a lot of different things during the unwinding. And I think now when we look at HR1 and some of the new changes, people have gone through very recently the
Hmm.
experience of what it's like when processes change and the fallout and the challenges of adapting to those things. So I can go into more detail on those things, but
Yeah.
hopefully at a high level, that's a good breakdown.
Absolutely. So we actually our first episode of the show was with Cody Kinsley, the former health secretary of North Carolina, and he talked a lot
Amazing.
about that process of like, what can we do? We're sitting here from a state perspective and saying, okay, we know this is coming. What can we do to sort of mitigate that? But it's very interesting to have you looking at it from the perspective of an innovator building technology to help with this as well. Um, just really quickly for the audience, many of us, you and I, we understand the many of the complexities of the Medicaid program, but I think maybe talking a little bit about how you look at Medicaid broadly with the different populations, right? The expansion population and other segments of the population that receive Medicaid. Surely the redetermination and eligibility issues are different across expansion populations and other populations.
Definitely. And I think one other framing that's important too is imagine a household. You may have multiple different people that are on Medicaid or maybe an ACA plan that are qualified under different types of programs because fundamentally Medicaid is a means tested program, which means it differs from Medicare and that is more of a social insurance program, whereas Medicaid is if you meet these standards or these qualifications, then you are eligible for coverage that is subsidized or completely covered by the state and the federal government. So when I think about the different programs, all 56 states and territories have very different sets of rules related to what qualifies for TANF Medicaid, Magi Medicaid, Magi Expansion, working with disabilities. This is like the worst game of trivia ever, but we could go, give examples for many different states and different programs. The federal poverty level differs for also those programs and also differs as your household increases in size. If you're divorced, there's a couple more complexities related to what actually qualifies as your household, or if you have a partner you're not married to similarly. So that's just at a very high level, a little bit of a taste of what do the
The
qualifications
complexity.
mean and the complexities. Now that's just more around at a high level. When you get into the details of okay, income looks different by people, and you're also calculating income a little bit differently if you're looking at the specific month, if you're actually projecting out for the year, and which those things the state might be using to decide what their income thresholds are for Medicaid. The way that people report that or think about reporting it or have access to verified information looks different by state and by program, and also depends on the systems that the state uses. And this is before we get into the next phase, which
Yeah.
is when the state and or the county is processing, how long they take to process, what tools they have to process, what ways they have to communicate back to the enrollee. As you can imagine, entirely different state by state and county, even by county in the 26 states that have counties involved in the Medicaid
Yeah.
adjudication
Like
process.
California, like here in California, we have counties doing all this stuff as well. So just add that complexity.
Exactly.
Exactly.
Yep.
Let's put a pin in the work requirements and the work piece for a little bit later, and
Sure.
let's go back a little bit because we there's a lot to talk about there. Let's go back to the 56 system challenge idea, right? People think of Medicaid as one program like Medicare, which also isn't quite true, but that's fine. We'll just the complexity of policy is endless and goes on forever. But it is 56 different state and jurisdictional laboratories, if you will. Talk a little bit more about why it's so fragmented, and then really what you've built a lot of Fortuna on is what does it actually look like when someone's trying to enroll in Medicaid today, and how have you started to address that from a technology perspective?
Yeah, this is also a very interesting question. I'll try to break it down in easy ways so that it's a little bit digestible. But the program and policy setting is often, but not always, done by Medicaid or the Medicaid department. Sometimes it's the commissioner's office and it's a little bit more global. Sometimes it's the legislature, and sometimes it came through a referendum of how the policy was set for Medicaid. So even that program design component before you get into implementation is a little bit state by state. We talked a little bit about the counties, so maybe we won't get into some of the details of that. But when you think about the systems then that are built to respond to when a program design happens, that system or the technology is often done by sometimes a completely different agency. So to give you an example of that, in the state of Utah, the program design is of course done by Medicaid, but the actual adjudication, so when somebody submits an enrollment or a recertification, that's done by a different agency called Workforce. So when
Wow.
I know, the complexity is fascinating. And what I think is really special actually about the Medicaid program is that states are very different. What you might need in a rural state versus an urban state, or state that has an entirely different set of or preponderance of folks in a certain type of work versus others, you do want different things then for that state. And so I think that's something really beautiful about Medicaid, and we should always celebrate the autonomy that states have around being able to do that. But it introduces the fragmentation that I'm describing a little bit. The second part of just the program design and process of how you actually implement that I described up front is the systems. So many states have systems that are over a decade old, about 40. 13 or so of them have two concurrent systems running at the same
Wow.
time. Many of them have three concurrent systems. Some of those
Great.
have duplicative and or information that just isn't correct. And so as an enrollee, to then get to your last question, the way that you often experience this is sometimes through a digital experience, often through paper, sometimes through mail, sometimes going to the county or the local Department of Social Services and going through an enrollment or recertification there. The steps that you might need to take after that may involve more paperwork. Some of that's digital, but oftentimes it is, hey, we identified additional income. Can you verify or provide additional information on this? Different states have different turnaround times, even on that. So a state like Texas and Iowa often have a 10 to 15-day turnaround window by the time that that information is sent to you. So all of those nuances that an enrollee experiences is the things that we think about on a day-to-day basis, because if you are going to be building, right, this TurboTax for Medicaid, you need to really care about the details of all of those things to be comprehensive and successful when you're supporting an enrollee through the process.
Right. I mean, if you're building technology, often you'll think, okay, well, here's a number of use cases, and then there are some edge cases. And we can generally handle the use cases that we know. And then the edge cases, we probably can't handle all the edge cases. But it feels like in Medicaid, these are all edge cases.
Mm-hmm.
There's just so many of them.
Yes, it's almost entirely different. When people ask me a lot, oh, where do you use AI or how do you use LLMs, et cetera. It's kind of a different problem, actually, and a different set of things that
Mm,
Medicaid navigation should focus on if you're going to be successful. The processes that we were describing, it's not something you can, run an LLM on and identify here is how it works. That is not the way. There's no run it, an AI through the giant set of eligibility and enrollment rules. That maybe gets you 30 to 40% there. But then the process of, okay, what if you, Lisa, submitted an application in the last 5 years? That means you're not net new in the system of record. So the way that states respond to a not net new application is entirely different. Some of them
mm,
say you actually can't submit a new enrollment unless you call the state, you identify the caseworker that your actual application went to, and then you have to go through a call. There's a call based approach to unblocking what we call internally a hung application. Sometimes what's really challenging about that is if you were an applicant on somebody else's enrollment, how are you splitting up your ID and your status from somebody else that's already in the system? These are not things that today AI is perfectly suited for, but there's certain ways that
mm.
you can definitely bring in AI and LLMs to make certain aspects more efficient, at least on the enrollee side. But also, I'm really excited for what certain automations could be for the state, because I think they're often, when we paint these narratives and the stories, the people that I feel like are the least represented are the eligibility workers that sit on the side of looking at all these
Sure.
applications, the caseworkers that are looking at applications who have not had new tools provided to them in decades. And so maybe this moment of urgency and crisis will be a moment to empower them with new tools and infrastructures that ultimately help enrollees as well.
Yeah, absolutely. Let's talk about churn generally. We there are numbers which now are quite a bit old, right? At least 20% of Medicaid enrollees are churning annually, and then folks are earning and regaining, losing coverage within the year, even many cases. What's driving this tremendous amount of churn?
So I would say it's two things. The first is Medicaid is not a static status, right? Your situation may change related to having a child or losing a job or getting married, et cetera. So because of that, there are different circumstances that arise in, let's say, a 12 months that somebody generally could qualify if nothing changes about their situation. So assuming something like that changes, like a life event, there will be added complexity to the steps that you need to take. But the second part I would say is largely related to, other than if you lose a job, et cetera, it's, do you know the steps you need to take and can you take them to either recertify or to provide the state with additional information on your situation? So let's say 6 months in the year or 6 months into your coverage, the state asks you for additional information. The second part of the equation, if it's not something like, your income changing, is, do you know the steps that you need to take and how to take them? So let's say 6 months in, the state requests information from you. Do you know where you should submit it? Is it going electronically? Should you mail it in? Should you fax it in? Is there a specific person or agency or name you need to put on there? What type of documentation do you want or do they want you to provide? Is it pay stubs? Is it a letter from an employer? Is it something else? A lot of those are not made very clear. So when you add both of those things together and then the addition of there may be multiple people inside your household, and maybe even if they're in your household, they don't live together. So you're collecting a lot of different pieces of information. You need to know how to, submit that. You need to know what you're submitting. You need to do it within time. And often those things, because they can be a moving target for folks, particularly when you think about the Medicaid population, and how generally folks that are low income and under resourced don't always have either the time or sometimes don't fully know because it's not clearly stated in sixth grade language how this should be done. Churn becomes a problem when you stack all of those things on top of each other. And that's before, if we want to get into HR1, before thinking about work requirements
Yes.
and even more recertification.
Right, definitely. Well, let's go into that, right? HR1 is introducing work requirements for the Medicaid expansion population. Work requirements, community service requirements. There's a few other ways to meet those requirements, at least in the information we have so far, right? Writing a law, creating policy is the easy part. Implementation is the extremely hard part, and there are lots of details there. And then you also have the level of the 56 systems and different jurisdictions and states that delegate down to counties, right? Like how this gets implemented in real life is going to be, I think, quite complex. We also have not great examples from the past, right? In Georgia's Medicaid expansion work requirements program has been quite complex. People have lost coverage when they shouldn't have lost coverage. People who are definitely working but have a whole variety of different issues that make it hard for them to certify based on the requirements. I also think about some of these, you talked about some of these aging state systems, right, that may not work very well, may not be easy to access on a mobile phone, where services might not even be available weirdly 24 hours a day, right? Like I never knew a website could shut down until I started working in government systems, right? Like I
Hmm.
didn't know the website has a 9 to 5 working hours, but that's great. So just things like that get added to it. So we know that from the data that most beneficiaries are already working, caregiving, going to school, whatever it is. So what's the real challenge here? Like talk about work requirements and what you're looking at in terms of implementation here.
Yeah, I would say what, especially doing a diagnosis of programs that have happened in the past or were designed and maybe didn't actually go into implementation, like some states other than Arkansas and Georgia, the outreach and the engagement piece from the state is really important. If people, again, going back to what we were talking about earlier, don't even know what they're supposed to do or how to do it, they're going to be unsuccessful to begin with, especially if
For
you're
sure.
making a program change. So even with the new rules of HR1, that I think is core to being successful as the transitions happen. The second part, and this is kind of an uncomfortable aspect of policy and implementation, which is the first thing may not always work. And if the first thing doesn't work, how do we, in the words that you used earlier, actually be closer to a laboratory? And the first thing may not work, the second thing may not work. Perhaps it's going to be the third thing. Can you actually set up some type of design and implementation and also tech to be flexible as soon as you find out that a process is not working? How do you iterate and go from there? I think that's very common in the tech ecosystem to have that sort of mentality, or health tech companies have that sort of mentality. But when I think about states and a lot of the vendors that they work with that are a little bit more monolithic, it's a lot harder to do that successfully. So, because it can take a really long time just to set things up, even when you identify that things are running into problems, how do you fix that or iterate or make a change? So, when I think about how when states are going to transition and make some of these changes, can they think, or how should they think about that? The first thing may not work, the second thing may not work, but can they create the tiger team that's working on this, which is almost always a combination of the state workers, state leadership, vendors, consultants? How can you create that sort of dynamism in your process? Because sort of inevitably, and again, looking at Arkansas and Georgia as the example here, there will probably need to be an iterative approach in how work
Mm.
requirements and recertification changes happen.
Right. I mean, let's take the framers, the writers of this bill at their word, right? We care about program integrity. We believe that, Medicaid expansion should be tied to work or some meaningful community engagement. And yet, of course, the CBO is estimating that, millions and millions of people will lose coverage here, in spite of most of those people actually being eligible, leading us to believe this is about sort of the paperwork and the systems. Like why are say more, how are these people who are eligible for Medicaid expansion but maybe at risk of churning or being kicked off of coverage, why are they not able to actually certify? Is it that the type of jobs they're doing? What is it, just the technology? What's the issue here that's creating that gap between the jobs people are actually doing and their potential loss of coverage?
Yeah, I think if you take, let's say, ex parte out of the equation, so let's imagine that if we are making this change, the first thing I would be doing if I'm a state is making sure that I have a bunch of different data sources that I can pull from, assuming that cost is not prohibitive, because there are
Right,
costs as well associated with
for
those
sure.
things. But putting that out of the equation, There
Nobody
are
likes to fund the implementation of a law. Let's just say
Oh,
that.
for sure. No, exactly. And there are different costs associated with if you want the most comprehensive data verification, that's probably going to be far more expensive than a 50% data verification, 25% data verification.
For
And if you're
sure.
a state that, over 40 states have a budget shortfall right now, particularly on Medicaid, that is actually something that people need to think about because their budgets and budget solvency and fiscal integrity is a huge plank of Medicaid for almost every state. So putting again ex parte aside, just because we'll get into a whole can of worms about that, the reporting mechanisms or finding ways to verify and prove work or community engagement is actually hard, right? For about 46% of working enrollees, so not even going into the examples of folks that have an exemption because they're a caregiver, et cetera. Most of those folks are people that are self-employed. They're hourly workers that have very variable overtime or may not work, let's say, a couple of weeks of the month. And seeing that in real time is very challenging because many of them are not connected to traditional PEOs. Maybe they don't even use a PEO at all to track that. Another example is people that have cash pay jobs. So they do everything a little bit off the books. How are they supposed to report or have a consistent way of reporting what their income looks like? And last but not least, seasonal workers. I know that CMCS is going to be working on technical requirements and sort of setting a framework for
Sure.
even thinking through this type, this population or the variable working population. But it is actually challenging to figure out how do you create a way to report that information accurately in the ways that are appropriate based on what the state wants as each state rolls out its own version of this. So that's a true design problem, user experience problem, et cetera, and it needs to be taken very seriously. Particularly going back to what you said, if you're taking folks at their word and how this policy was written, also how CMS and HHS roll it out, that is going to be really important. Then the other aspect of finding the exemptions, I think there are some data
Mm.
sources you can pull from. As an example, there are certainly, even in medical records, if that is going to be included as a verification source, you can definitely identify certain conditions that are under the exemption requirements, even using some proxy information on the caregiver side. But again, stitching all of that together is actually a real implementation problem. It's easy to say, oh, you can do these things, but in theory, we could have done them 10 years ago. Sure,
Right.
maybe not with AI, but in theory, you could have done this 10 years ago. But why didn't it work then? Is a lot of the same reasons. It's going to be really challenging this time around.
Right, exactly. Yeah, I mean, I don't think that I truly, from my experience, don't think that most people are sitting around. People have all kinds of things in their lives that are going on, including different types of work and all kinds of caregiving and other situations like that. But it is very hard. There is a cost and a huge amount of time, and I think also better technology needed to help make this work. I guess, oh,
Absolutely.
yeah, a
Oh,
little
can
bit
I
on that.
throw in with an
Oh,
example,
please,
actually,
please
Lisa, if
come
it's
in with an
interesting?
example. Yes.
So when we have had these conversations with both states and health plans on, oh, but there are data sources for some of these things, we share some real examples of there are PEO systems that, let's say you're
PEO,
working in a
professional
warehouse.
employer organization, like the
Exactly.
HRIS, HR information system, or something that basically shares that payroll information with other parties in some way.
Exactly. You're spot on.
Yeah.
So let's say paychecks is an example, Rippling
Yeah.
is an example. So they might say the income, but they don't say anything about hours. And so hours, if you set that as a requirement as a state, well, you don't actually have a verification source for the hours. And then we also know at certain slaughterhouses, again, they may have a PEO, but people clock in and clock out on an iPad that is disconnected from any sort of verification system. So the rubber really meets the road. And do you know, as either a state or whoever the state is working with on designing these things, do they care about the true details, like the ones I'm articulating? That actually matters if you're going to do this successfully. If you believe at a high level, oh, this data exists, but you don't actually know that hours don't exist anywhere in the system, then you're actually starting from you've asked the incorrect questions to begin with. So your
Yeah.
solution is going to be wrong.
Yeah, no, those are really interesting examples that probably are absolutely going to hit these states when they try and do this work. It sounds very much like, unsurprisingly, this is a project that will take deep engagement across the public and private sector if we really want to make it worth. And then you go down to, okay, what's the cost? And then what's the
Hmm.
outcome? And I think, this is really going to be the question. Does the cost outweigh any societal benefit? And I don't know the answer to that. I think that's kind of where I get to the next question, which is like, you're working in an area that is incredibly political and has only gotten even more political and even more partisan. I think I get from you, and knowing you for a while now, I think, you're very focused on the policy and getting the actual job done and just work moving forward. Like, how do you balance the partisan issues here that are absolutely affecting the trajectory of the work that you're doing?
Yeah, I think if I just take a step back and think about what's our North Star as a company, it's always the consumer and it's always the enrollee. So I look at it from their perspective. Policy is moving always. You have the unwinding, you have ACA expansion that hit Medicaid. You can keep going back to disability programs, et cetera. Medicaid is going to always be a moving target. In that way, it's sort of like an accordion. And so given that, you can't just make, even build a company, I think, off of one regulatory change and hope that that regulatory change sticks around forever. So our North Star is there are millions of Medicaid enrollees. What do they care about? And how do we support them through the experience of enrollment, recertification, despite whatever changes the state, the county, or the federal government might have, so that there's always a resource that they can trust. That's actually one of the big things that I realize is often missing from the conversation, even around policy, is trust is a little bit different and sits outside of the actual policy and implementation and technology. It's this amorphous thing, and it's something that is really, really hard to earn. You don't just get it because you're X institution. So if we think about and have the North Star of the enrollee and the beneficiary, then knowing that to serve them best, we need to continuously earn their trust. It's just demonstrating that no matter what the policy is, we will always be here as a company that
Mm,
specifically answers your needs and can navigate you through the process. And sometimes, Lisa, we navigate people through the process and they're not happy with the outcome.
sure.
We can't change that, unfortunately,
Right.
because
You have to
of the
follow the rules
policy.
of
We have to follow
eligibility
the
and enrollment.
rules.
Yep.
Exactly. We don't want to be doing anything improper or inaccurate, but that still meant that we followed the North Star. So hopefully that's a answer
Yeah.
to your
Yeah, yeah,
question.
yeah. So let's put ourselves in, in the shoes of a state, right? States and
Mhm.
their people, like you said, at the Medicaid agency or elsewhere in the state government who are like, okay, we've got to do this, right? We've got to figure it out. And also generally are looking for solutions to make eligibility and enrollment better, right? What's the pitch from Fortuna, and how do you fit into this? We understand the state landscape, and particularly the Medicaid landscape, to be really dominated by a few large companies who've been building technology in the space for a long time. One of the things about government procurement, right, is that often favors companies who have been doing it for a long time and understand all the rules of government and public sector procurement. Like, what's sort of the pitch of Fortuna here for a state who's trying to figure this out, who says, like, I got all this policy stuff happening, I have to make a change, I have to do something. Like, how do you play in that market? When a state or an MCO is evaluating you, what are they comparing you against? How are you positioning yourself to help them solve this complex policy problem?
Yeah, it's actually a great question. I think one thing that's unique to our company, in maybe comparison to some of the ones that you mentioned, is we built bottoms up. A lot of the companies that you're describing have correct, they contracted with the state to build out an eligibility enrollment system, an E&E, or maybe the Medicaid Management Information System, the MMIS, and they have built those directly for the state and for the state's needs at different points in time. That is just a very different place to be coming from as a company versus we started from the enrollee perspective. We know the perspectives of hospitals and health plans because they're the people that, buy Fortuna today. And so we just bring a very different narrative and story when we're talking to them. We also know their systems and infrastructure in a very different way than some of the current and existing vendors do. We've in some ways experienced it as an enrollee. We know where there may be opportunities to improve in ways that maybe because some of the vendors that they work with today are too have approached it in a different way, they don't see a lot of those in the way that we do. And so I think that's a big part of why we're very interesting to states, why they like to talk to us, because we're not policy people. So that's one. So we're not consultants the way that some other companies are. Two, we're not a monolithic vendor who has also years of technical debt, et cetera, that you have to unwind if you're going to do
Mm,
things differently. We've shown that we have a North Star. We care about your enrollees. We care about your beneficiaries, which every Medicaid department cares about, or Medicaid agency cares about. All the commissioners of health care about it. The governors care about
right.
it. And the second part is we don't have the technical debt that other organizations have. We've built very nimbly. We've built very modularly. And the third aspect is we have a lot of proof points of that. We have outcomes. And I really pride myself on this. And this is something I know you think about too. Vendors suck generally. Almost everybody hates their vendor. And I get that. And as a vendor, I'm like, okay, I need to think about this too. It makes me feel amazing that our health plan partners love us and our health systems love us. And I know enrollees we work with also have obviously positive feelings, but it is so different and unique to me that I can bring in references from health plans and health systems that we work with, and also states that we in different ways have a relationship with because of the work that we do. And that you can't buy. You can't buy people thinking that you care deeply, you have a lot of integrity, and you have outcomes, and they're willing to just say that and be a reference to other folks. So, sort of a long-winded answer of why I think we're a little bit different about the where we came from, who we are, and I think the outcomes that we've delivered. But I hope that that speaks volumes for Medicaid can be done differently. The ecosystem and the technologists that build in this space, if we do anything right, regardless of what happens to this company, if we can create a wave of new people that want to improve the infrastructure that's built here, then whether or not any states work with us, that'll feel like a really amazing legacy to leave.
Right. I mean, I think again, going back to when you were founding the company, and there was a little bit of a wave of like, oh, there might be some innovative technology companies who are building for Medicaid. I don't know if that wave has crested yet, let's just say, to sort of bring that
Yeah.
analogy out. I think, as we've noted here, right, Medicaid is quite complex. And I think understanding ways you can profitably build a technology company that also is like serving enrollees, right, which is a sort of a for benefit type of mission. I think that remains to be seen. And I don't know, I don't know who else is really, I don't know that there's really been a huge wave of folks, building innovative technology for Medicaid like we were thinking there might be. Now, who knows, right? This might be another moment in time where the critical need for better technology to serve the Medicaid program and Medicaid enrollees, right, comes to light, but it's quite complex. I mean, I think for you all as well, your model means that primarily at this point, like payers and providers are funding the surface. There's a little bit of interest maybe in some communication with states, probably especially now that the work requirements are coming back through HR1. How do you think about that? How do you think about who funds your service versus keeping enrollees top of mind?
Yeah. I think anybody honestly can fund our product as long as it's not enrollees, because obviously this is a program for people who are low income. And I would feel like we have done wrong by our mission if they are paying for the product. I'm very agnostic to whether it's the states, health plans, health systems, even CMS. I think CMS has actually raised a lot of interesting and important points. They're not
Mm,
incorrect that there are people enrolled in the ACA and in Medicaid at the same time. That's usually a technology problem because these exchanges are not always connected to each other. So it's correct that things like that happen. Second to that, because a lot of counties are involved, as we talked about earlier, there are often delays that are because of manual reasons. So they've pointed out some really important aspects of improper enrollment and improper payments. Even there is truth to those things, but whether and how states or CMS step up to fund and also listen and work with folks that are coming to the table to say, we have a lot of this information, because
mhm.
it could be existing vendors. Also, health plans have a lot of this information. State eligibility workers that have been knee deep in this for years have a lot of this information. And I hope that they come to the table to design whatever CMS and CMCS promote or at least make available. But again, different way of answering your question is very agnostic to who is interested in funding our work and how that work gets into the hands of enrollees, as long as it gets into the hands of enrollees and
Yeah.
beneficiaries.
Yeah, when I hear, oh, there's people who are enrolled in multiple Medicaid programs and ACA programs, I think that is an administrative issue where something didn't get updated, or it's a fraudulent issue where a person was signed up for something without their knowledge or consent, right?
Definitely.
I don't go anywhere else beyond saying like this is because you have 56 different systems plus ACA, and they're all not communicating with each other, and there's no verification across these 56 different systems in
Yeah.
a meaningful time frame.
Totally. I mean, some of it's an awareness problem of, we see this in our own product as well, where people are moving to a new state and they think you can just port, Florida Medicaid eligibility over to Nebraska. Totally different
Nope,
Medicaid programs. But an enrollee doesn't know that. And I understand why they wouldn't know that. So oftentimes there might be duplicative enrollments because somebody's moving. And I think that it's the right thing that, the feds have called out. Paris match can be improved. There could be improvements here,
for sure.
100%. But a lot of it is, again, what you said, it's awareness versus it potentially being like something that people are trying to do fraudulently. Because also, what's the point of being enrolled
Doesn't really help
duplicatively in
you.
states? It doesn't help
Right.
you. Yeah, it
Right.
meaningfully does not help you. The
No,
other
that's
part,
right.
and I think this is actually something we really thought about in the early days of the company because we didn't understand, and this is probably some of our naivete. We were not sure why brokers didn't help people with Medicaid. We understood, okay, you're not paid for it, but why, if your goal generally is supposed to be to support people? And actually, in most states where you do broker training, et cetera, you are supposed to still help people navigate on the Medicaid and the ACA side. But why does nobody do it? A lot of CMS, but also white papers, et cetera, have correctly pointed out that brokers do not have the right incentives often related to enrollment. And there are, because 80 to 85% of people that enroll in the ACA are done through brokers. There are bad actors. And I agree with there being more controls over
Yeah.
those types of things. But that does not mean, and I don't think it means the majority of people in the Medicaid program or the ACA program are out there trying to commit fraud. I think it's awareness, it's technology, and it's making sure incentives are really aligned to do things the right way.
Yeah, absolutely. You talked a little bit about in the beginning in creating Fortuna, you said we think this is at least in part a technology problem. How do you like break down for me where technology can help versus where there are fundamentally real policy issues?
Yeah. So, because we're not policy people, I actually can answer this
Right.
question pretty directly.
Great.
On the Annie side, there is the user experience problem, and we can describe that in many different ways, but it's a really meaningful one. So, just what those systems look like, because a lot of them are built 10 years ago. It's like looking at AOL, right, versus more of a modern user experience. And Medicaid beneficiaries, 95% of enrollees have a smartphone. So and a lot of state systems are built this way, they're not built to even work on a mobile phone. Okay, now somebody has to go find a desktop or a laptop. So there's a lot of just general design form factor problems that can definitely be improved this time around. Then the second is updating and making the logic very clear, particularly for complex households and circumstances, people that speak different languages. There is a lot that can be improved around that, and making it really clear when an enrollee runs into, let's say they're recertifying or enrolling an error. What does that error mean? What are the next actions and steps that enrollee should take? Should that enrollee call the state of health, or should they call the Department of Social Services? Or maybe there's a different way to unblock. So just some of those response mechanisms and how the technology is designed, I think is really important to get people through in the right ways. The fourth is there could be far more real-time adjudication. There's only a handful of state systems that have that, but because counties are involved often, or there are multiple systems, or you just don't have a real-time adjudication, there are wait times. That wait time can range from, if not real time, a couple of days to 30 to 45 days, sometimes even longer than that. And so are there different automations or different verification sources or different rules engines that states can build with their partners to make those things a little bit more consistent? And that's more upstream. So when you get to the downstream part of what is the processing on the side of the state? So of course, verification systems, I think, are things that can be improved, whether it's adding new sources or updating sources of information, making those also more frequent instead of receiving that information every quarter or maybe every half a year. Can you use internal systems like the Department of Labor information or new hire database, things like that, that make the process more smoother for an eligibility worker or a merit worker on the side of the state. And then there's also a lot of just automation and RPA that I think that states should definitely look into. Very repetitive processes that
Hmm.
workers might be doing that if you could alleviate that off of them, could they either be more efficient or focus on more complex cases that people care about? I could go through a laundry list, but I think there's so many opportunities from everything that we've seen. There's low hanging fruit, and then there's maybe if you explore a new approach, could it actually be a step function improvement in E&E that actually unlocks cost savings? I think there's lots of different ways to cut it, but maybe if I was a state looking at this, I would probably do a general analysis of what does the process look like end to end for me as a state, for an enrollee, and for a worker, and then identify are there actually big gaping holes that if we add in work requirements
Right.
and increase recertification, this particular area is going to be very stressed, and focusing on that just to be precise in making changes, and then taking a step back and going, okay, now that we've maybe identified those parts, what would we wholesale change if we could?
Right. Not at the risk of kind of repeating myself a little bit here, say a little bit more about why we can't just, slap some AI on this and magic the whole process, right? Which I know that I'm sure that there are some people in states and some people at CMS or CMCS who are hearing stories about, oh, we can do all of these great things with AI. Like, why can't AI do these instant Medicaid redeterminations? Why can't we just very simplistically, like, why can't we just do that? Which is what I'm
Yeah,
sure some people are hearing.
there are definitely things that AI can improve. Don't get me wrong. But when I think about what aspects are still not entirely solved today by I would say it's a lot of those complex circumstances. That is a lot of Medicaid. A lot of Medicaid is actually not a straightforward case. I wish that would make Lisa our building of our products so much easier. Oh my gosh, I wish that was the case. But um, adjudication, when you have some of the right information, only works for about 50% of people. So if you know that ex parte processes is only going to work for 50% with verification sources, that is that's applicable. But for everything else where you've been enrolled before, maybe you're splitting up a household, maybe the county's involved for some reason, maybe there's different conflicting data, maybe they're eligible for multiple different programs at once. Today, because the states often, or let's say eligibility workers, are trained in different ways and have different sets of information, a lot of it sometimes is a change management problem or a challenge of what is actually the right pathway. And the states need to decide those things on their end before AI can come in and take over. So there's some upstream, more design problems or decision problems that, once those are smoothed out, then I think AI can be a little bit more powerful. That being said, there's a lot of step function progress also happening in AI right now. And when I think about specialization also helping, right? There's a reason people use healthcare AI companies versus the general AI company, because the
Sure.
more use cases you have, the more you know, the better you can get at it. And so I think, and this is more of when I think about Fortuna as a company, when AI becomes more useful for a lot of aspects of our business, you bet we're going to be one of the first companies
Right.
in there to be using it. Like we, of course, but there's a lot of things today we know that AIs or even LLMs does not solve the problem. And if you're truth seeking, it becomes more about what is the problem and how you're solving it, not what is this new fanciful technology and how does that solve the problem? That's asking the wrong question. And so I think in a moment that does require truth seeking to solve the right problem and get to the right answer, it has to start there versus start with, oh, AI can solve stuff and then proceed.
Right. Yeah, that's definitely Innovator's stance as well with regards to having deep context in healthcare. You can build all kinds of cool stuff. We can build all the agents, we can build all the co-pilots, but you need to have that deep data
Yep,
context and that understanding of where something is coming from and what it actually means. And you've got to do that work first. You have to do that work
totally.
first. You can't
Totally.
just slap it and the AI on it and make it magically work. But I think Medicaid offers lots of interesting lessons there because of the incredible complexity and the long tail for sure.
Yeah. One other thing maybe I'll add, because I think this relates back to that. Um, we actually, our engineering team has a engineering principles for Medicaid document. And I think
Ooh,
it's really
nice.
awesome because you have to care that much. And so it means that there's certain ways that they approach problems from an engineering perspective based on everything that they know, having built for Medicaid over the past couple of states that we've done, which I love. And the team wanted to do that, not me. And so I love that there's a culture around asking the right questions and then designing the right principles based on that. And so I would encourage particularly any company that's thinking about doing things in Medicaid or even touching E&E, you need to have those because that's really, really important to doing it right.
Nice. So, to close us out here, we think a lot about the policy stack here, right? The intersecting layers of, in this case, federal, state, local, county, MCO, health system policies, whether it's a law or regulation or guidance or some kind of organizing principle. Can you give any examples or think of any examples about how these many conflicting, potentially conflicting layers have sort of interacted or intersected to make a life more complicated around Medicaid eligibility, enrollment, redetermination, et cetera?
Yes, definitely. I'll use an example of disability. There's many, but I think this was an interesting one. Um, if you qualify for a disability, that means a lot of different things depending on state. Social Security disability identification is done at the federal level through SSA. But states also have their own working with disability programs that have different ways of identifying and qualifying things as equaling or not equaling being disabled within the eyes of within the eyes of the Commonwealth, let's say. That is a big problem if you don't understand the nuances of what steps you might be taking, because maybe the worst path, I'm just thinking from an enrollee perspective, maybe from a clinical perspective, you are somebody that would qualify through the SSA pathway. The state may also have a pathway, but the state pathway will take you 60, 90 days. The SSA pathway that might have maybe some different care delivery or maybe different options available to you. That path, though, takes 2 years. So those different types of trade-offs are things that enrollees may not know, but is a place where policy intersects and conflicts with each other. So we as a company are making those types of decisions in concert with an enrollee to then figure out how should we build that out. And that's just one example. So when you think about programs for people that are pregnant or young children, CHIP conflicts with Medicaid, so you may have overlapping qualifications. Florida is an example where Kid Care has many different variations of the program. Knowing and understanding those things and where policy intersects and making and thinking about the trade-offs of what would be best for an enrollee, but also their clinical needs, their care needs, their family needs. That's where overlapping policy meets how are you going to implement it? And that needs to be done really, really carefully and thoughtfully.
That's awesome. Well, I really appreciate you joining me today. Any final words for the audience of the policy stack about the critical role of policy and building better technology for Medicaid?
Yes, I would say that this is a moment where everybody needs to come together. I think there's many times where people are sitting on opposite sides of the table and it's not a moment to collaborate. Moments of urgency like this require everybody coming to the table and being partners. So that would be my final, last parting words.
Awesome. Thank you so much.
Thanks, Lisa. Thanks for having me on.